Welcome to another deep dive. We've got a really fascinating one for you today. Have you ever wondered what a doctor notices about you before you even say a single word?
Oh, before you even open your mouth.
Right, like before the stethoscope even comes out of their pocket, or before they even ask, what brought you into the clinic today. There is this massive, incredibly detailed medical story that's already being told.
It really is. The human body is basically a continuously transmitting beacon of physiological data.
Exactly. It's being broadcast by the angle of your posture, the way your clothes hang on your frame, the subtle hue of your skin, and even just the cadence of how you say hello.
We tend to conceptualize medicine as something that officially begins the moment the formal physical exam starts. And the doctor says, take a deep breath.
Right, the official start line.
Yeah, but the reality of clinical evaluation is that it activates the absolute second you become visible in the waiting room.
And today, we're taking a massive stack of medical sources to uncover the mechanics of that invisible observation.
It's a great stack of sources, too.
It really is. We're pulling heavily from the legendary Bates Guide to Physical Examination, specifically diving into the chapters covering the general survey, vital signs, and the mental status exam.
The foundational texts.
Right. And we're also bringing in these clinical lecture transcripts from seasoned diagnosticians. Plus, we're even throwing in highly complex medical coding matrices to see how all this granular observation actually translates into the business and legal structure of modern healthcare.
It is a remarkable collection of material because it bridges that gap between the intuitive art of healing and the rigid, systematic science of diagnosis.
The mission for this deep dive is to decode the secret language of the human body and mind. We want to give you, the listener, the ultimate shortcut to understanding how clinicians are actively trained to observe the world.
Because there is a profound difference between simply looking at someone and actually seeing them.
Yes, exactly.
Observation in a clinical setting is an active, strenuous, and highly systematic skill. It requires intentionally peeling back layers of inherent human bias.
Which is really hard to do.
Oh, it's incredibly difficult. Every single one of us looks at the world through the specialized lens of our own daily experiences. Clinicians have to undergo rigorous training to basically strip that default lens away so they can perceive the unfiltered reality of what is actually sitting on the exam table.
To really understand how they do that, we have to explore the foundational concept of the general survey. The medical texts draw a very sharp, crucial distinction between what a patient verbally tells the doctor and what the doctor silently observes.
Right. They contrast the general survey with the review of systems.
Break that down for us. What's the difference?
Well, the review of systems is entirely subjective. It's the narrative you construct about your own body. If you report experiencing a sharp pain in your abdomen, or you mention that you felt dizzy for 3 days, that is subjective data.
Because the doctor can't feel your dizziness.
Exactly. The general survey is the counterbalance to that. It is the objective, systematic cataloging of your physical state, your vitality, your body habitus, and your demeanor, gathered purely through the clinician's senses.
The texts point out that patients usually come into a clinic for what are known as constitutional symptoms. We're talking about the vague, heavy-hitting complaints.
Unexplainable fatigue, generalized weakness,
sudden fevers, severe chills,
night sweats, or unintentional weight changes. Those constitutional symptoms are notoriously difficult to pin down because they are entirely nonspecific.
Right, like fatigue, everyone gets tired.
Exactly. Fatigue is a perfectly normal response to a demanding work schedule or acute emotional stress. But it is also a primary indicator for clinical depression. Insidious infections like mononucleosis or hepatitis, endocrine system crashes like severe hypothyroidism.
Or even the early stages of congestive heart failure.
Or significant underlying anemia. When a patient reports the subjective feeling of profound fatigue, the clinician immediately deploys the objective general survey to hunt for the subtle, visible clues that narrow down that massive list of possibilities.
The divide between feeling that something is wrong and actively observing the mechanism of the illness brings to mind this incredible anecdote from one of the clinical lecture transcripts.
Oh, the train story.
Yes. The lecturer was recounting a time she was traveling on a train to New York. She was sitting across the aisle from a woman, and she got this overwhelming, nagging feeling that something was clinically off about the passenger.
Just a gut feeling.
Right. She ended up staring at this woman for the majority of the train ride, racking her brain, trying to process the visual data. It wasn't until the very end of the trip that her brain finally isolated the anomaly.
The woman had absolutely no eyelashes.
None. It took her hours to figure it out.
That story is a perfect illustration of how the human brain processes visual information holistically rather than analytically. When we look at a human face, we don't scan it feature by feature like a barcode reader.
We just take it all in at once.
Exactly. We take in the entire gestalt, the whole picture. When a subtle anatomical detail is missing or altered, our pattern recognition software throws an error code. We feel a vague sense of unease or unfamiliarity long before our conscious mind can articulate the specific missing variable.
But in a fast-paced clinical setting, a doctor can't rely on a vague something is off feeling.
No, they don't have a 3-hour train ride to figure it out.
Which is exactly why the general survey is taught as a rigid, step-by-step mental checklist.
A clinician cannot wait for the missing eyelash to suddenly jump out at them. They must systematically evaluate the head, the hair distribution, the facial symmetry, and the ocular structures.
A systematic approach forces the brain to look at the granular details.
Pinpointing exactly what that missing eyelash represents, which could be anything from a systemic autoimmune condition like alopecia areata to a compulsive pulling disorder like trichotillomania.
The flip side of that holistic processing is observation bias. This is where you become so specialized that you only see what you are explicitly trained to say, and you completely ignore massive anomalies outside your field.
Right.
The lecturer shared this brilliant secondary story about her husband, who happens to be a plastic surgeon. They were walking down the street in San Diego, and a woman walks by them with very prominent breast implants.
And he notices immediately.
Instantly, the plastic surgeon husband effortlessly identifies the specific surgical technique used, noting whether the implants were placed above or below the pectoral muscle.
He is operating entirely within his domain of expertise. His visual cortex is highly tuned to those specific anatomical contours.
But just a few moments later, a man walked past the couple.
Right.
And this man has severe, extensive burns covering his entire face, his torso, and his arm. The structural damage is massive and unmissable.
Truly unmissable to anyone else.
Right. So the lecturer turns to her husband and asks what he thinks might have happened to the man. Maybe a chemical fire or a military accident. And the plastic surgeon husband turns to her and says, "Huh, what are you talking about? What guy?"
He completely failed to perceive a severe burn victim standing 3 feet away from him.
Because his brain was exclusively running the background software for aesthetic surgery observation.
That phenomenon is essentially inattentional blindness, driven by specialized medical training. Clinicians are entirely human, and they suffer from the exact same perceptual blind spots as the general public.
So a specialist might miss something huge.
Absolutely. If you put a patient in front of a specialized dermatologist, they might hyperfocus on the irregular borders of a microscopic mole on the patient's shoulder, while completely failing to notice that the patient's fingernails are showing severe clubbing.
What's clubbing?
It's a structural rounding of the nail bed that a pulmonologist would spot from across the room as a glaring alarm bell for chronic hypoxia and respiratory failure.
That is why the Bates Guide hammers home the necessity of the structured general survey. You have to actively fight your own brain's desire to filter out irrelevant information.
You have to force yourself to look at everything.
Let's break down the specific components of this survey. The texts go into a startling amount of detail regarding what a doctor is cataloging, starting with dress, grooming, and personal hygiene. Clothing tells a massive diagnostic story.
It really does.
The clinical lecture brought up a scenario of a patient sitting in a waiting room wearing a heavy insulated parka and a thick wool beanie in a 90-degree, unair-conditioned clinic in Waikiki.
Excess clothing in an inappropriately warm environment is a glaring diagnostic clue that immediately alters the trajectory of the visit.
What could it mean physiologically?
Physiologically, it could reflect the severe cold intolerance associated with profound hypothyroidism, where the body's metabolic furnace has essentially shut down.
And behaviorally?
Behaviorally, it could be an attempt to physically hide the severe, extensive skin lesions of psoriasis or the needle track marks associated with intravenous substance use.
The texts also note it could be masking severe anorexia nervosa.
In cases of severe anorexia, the patient is dealing with a catastrophic loss of insulating subcutaneous body fat, making them genuinely freezing in a room that feels sweltering to everyone else. The parka isn't just a style choice. It is a desperate attempt at thermoregulation.
The observation extends all the way down to the footwear, too. The sources mentioned evaluating the patient's shoes. Are the sides cut out? Are the heels crushed down?
Right. A patient walking in with meticulously cut holes in specific areas of their sneakers is broadcasting data.
It strongly suggests chronic, incredibly painful conditions like gout, severe bunions, or massive peripheral edema, where the tissue swelling in the feet is so extensive that putting on a normal shoe is physically impossible.
Even the smallest accessories are logged. The presence of copper bracelets might suggest the patient is actively seeking alternative, self-directed treatments for chronic joint pain or osteoarthritis.
And wearing sunglasses indoors is another major flag. The lecturer told a fascinating story about a young woman who came into the clinic complaining that she hadn't been able to sleep for 2 straight days.
Ah, yes.
She was wearing dark sunglasses in the dimly lit exam room. The clinician, following the general survey protocol, asked her to remove them. When she did, the clinician saw that her pupils were absolutely massive, dilated to the very edge of the iris.
The insomnia wasn't a sleep disorder.
No, the patient was coming down from a massive multi-day cocaine bender.
If that clinician had skipped the systematic visual check and simply taken the subjective complaint of insomnia at face value, they might have prescribed a heady sedative.
Which would be disastrous.
Fatal, potentially. Mixing a powerful central nervous system depressant with a system flooded with illicit stimulants could trigger a catastrophic cardiac event. Furthermore, sunglasses worn indoors serve as a universal red flag for physical trauma. They are frequently used to hide periorbital ecchymosis, a black eye.
The moment those glasses come off and trauma is observed, the clinical algorithm immediately shifts toward screening protocols for domestic violence and intimate partner abuse. Moving from sight to smell, the sources emphasize that odors are highly diagnostic.
The olfactory nerve provides a direct chemical analysis of the patient's internal metabolic state. The classic example is the distinct fruity odor of acetone on the breath.
That's a sign of diabetes, right?
Specifically diabetic ketoacidosis. When a diabetic patient's body cannot utilize glucose, it begins rapidly breaking down fat for energy, producing ketones as a byproduct. Acetone is a ketone that gets expelled through the lungs, literally turning the breath into a chemical exhaust vent.
The scent of alcohol is an obvious one, but the texts stress a very dangerous pitfall here. Never assume that the smell of alcohol alone explains a patient's altered mental status.
That assumption kills patients.
Really, just assume they're drunk.
Yes. A person smelling heavily of alcohol might simply be intoxicated, sure, but they might also be heavily intoxicated and currently experiencing severe, life-threatening hypoglycemia. Or they might have fallen while intoxicated, struck their head, and are currently bleeding into their brain cavity with a slowly expanding subdural hematoma.
So you can't just brush it off.
The odor of alcohol is a data point, but it must never be used as an excuse to prematurely close the diagnostic investigation.
The breath can also reveal the distinct, musty odor of liver failure, or the ammonia-like smell of uremia when the kidneys are failing and toxins are building up in the blood.
It's a chemical signature.
The clinical lecture actually included a truly harrowing story about the consequences of ignoring odors. A nurse asked a clinician to check on an elderly nursing home patient because the patient's breath smelled absolutely horrific.
I remember this one.
The clinician was slammed, rushed through the room, and simply prescribed a heavy-duty chlorhexidine antibacterial mouthwash from the doorway.
A textbook failure of the physical examination protocol.
A few days later, the smell hadn't improved. It was worse. The clinician finally stopped, put on gloves, took a pen light, and physically looked deep inside the patient's mouth.
And what did they find?
Hidden far in the back, behind the molars, was a massive necrotic tooth abscess. The tissue was rotting. The poor woman hadn't been eating a single bite of food for days because she was in absolute agony. And the terrible smell was the active spreading bacterial infection.
That narrative serves as a brutal reminder of a core medical tenet. You cannot treat a symptom in isolation. You cannot prescribe away an odor. You are obligated to locate the anatomical source of the decay.
Another critical parameter of the general survey is the assessment of the patient's level of consciousness. The Bates Guide outlines a very specific, escalating clinical ladder of consciousness. It is infinitely more complex than just noting if someone is awake or asleep.
It is a meticulously defined continuum. The baseline standard is alert.
Which means normal, right?
Yes. An alert patient has their eyes open, they spontaneously look at the clinician when approached, and they respond appropriately and rapidly to environmental cues.
If the patient is not alert, the clinician doesn't just guess. They begin a sequence of escalating stimuli to determine exactly where on the ladder the patient resides. The first step down is lethargic.
A lethargic patient appears visibly drowsy. However, when the clinician speaks to them in a normal or slightly elevated tone of voice, the patient will open their eyes, make eye contact, and answer questions logically.
So they wake up to your voice.
But the defining characteristic of lethargy is that the moment the clinician stops talking, the patient immediately drifts back to sleep. The auditory stimulus of a voice is sufficient to achieve temporary wakefulness.
The next step down into depressed consciousness is obtunded.
At the obtunded level, vocal volume is no longer sufficient. The clinician can shout, and the patient may not stir. The clinician must apply a direct tactile stimulus, usually a firm, gentle shake of the shoulder.
And do they wake up then?
The obtunded patient will open their eyes and look at the clinician, but their cognitive processing is severely delayed. Their verbal responses are incredibly slow, often monosyllabic, and they display obvious confusion about their surroundings.
If a physical shake doesn't wake them, the patient is classified as being in a stupor.
Stupor indicates profound neurological or metabolic depression. A stuporous patient will only arouse when subjected to a painful stimulus.
Well, what kind of pain?
Clinicians will typically use a sternal rub applying firm, grinding pressure to the breastbone, or they will apply intense pressure to the nail bed. The patient might groan or attempt to bat the clinician's hand away, but verbal responses are essentially absent.
And when you stop the sternal rub?
The instant the painful stimulus is removed, the patient collapses back into an unresponsive state.
The absolute bottom of the ladder is coma, where the patient is completely unarousable. Their eyes remain closed, and there is absolutely no purposeful motor response to any external stimuli, no matter how painful.
It is wild to realize that a doctor is silently running you through this diagnostic algorithm within the first 10 seconds of walking into the exam room.
Simultaneously, they're analyzing your motor activity and preferred posture. The way a patient intuitively positions their body in space is a massive indicator of internal distress.
For example, a patient suffering from left-sided heart failure will almost always refuse to lie flat on the exam table.
Because it feels like they can't breathe.
Exactly. Lying flat causes fluid to pool in their lungs, simulating the sensation of drowning. They will insist on sitting rigidly upright.
The sources also detail the tripod position, where a patient is sitting, leaning heavily forward, and bracing their arms firmly on their knees or the edge of the table.
Tripoting is a classic biomechanical adaptation. By bracing the arms, the patient fixes their shoulder girdle, which allows the accessory muscles of the chest and neck to pull upward on the rib cage.
Trying to force more air in.
Yes, forcefully expanding the chest cavity to draw in more air. It is a universal sign of severe respiratory distress, commonly seen in advanced chronic obstructive pulmonary disease or during a severe asthma exacerbation.
Clinicians are also constantly scanning for guarding figures, where a patient subconsciously holds a limb tightly against their torso to prevent any movement of a fractured bone or a dislocated joint.
They look for the shuffling, propulsive gait of Parkinson's disease, or the hyperactive, restless fidgeting that accompanies severe thyrotoxicosis.
They are essentially reading the biomechanical exhaust of the central nervous system.
I love that phrasing, biomechanical exhaust.
Before we close out the general survey, the Bates text spends significant time on weight and body mass index. They outline the standard BMI categories, overweight being a BMI of 25 to 29.9, and obese being 30 and above.
But the clinical pearl that really stands out is the distinction regarding the timeline of weight change.
The velocity of weight change is far more diagnostic than the absolute number.
If a patient steps on the scale and has gained or lost 5 pounds over the course of 3 months, that represents a change in cellular tissue, a loss or accumulation of adipose fat or muscle mass.
Which is normal biology.
However, if a patient gains 5 pounds in 48 hours, that is physiologically impossible to achieve via tissue growth. Rapid weight change over a matter of days is exclusively a change in body fluid.
It points directly to severe fluid retention.
It indicates that the heart is failing to pump effectively, causing fluid to back up into the tissues, or the kidneys are failing to excrete urine, or the liver is failing to produce the proteins necessary to keep fluid inside the blood vessels.
So tracking daily weight in these patients isn't about diet at all.
Not at all. It is about monitoring the immediate hemodynamic stability of their vital organs.
All of this observation fundamentally changes the fluid dynamics inside the blood vessels, which brings us to something that happens at literally every single doctor's visit across the globe. Part 2, the assessment of vital signs, specifically blood pressure and pain.
Blood pressure measurement is so ubiquitous that we often treat it as infallible, but it is a complex mechanical process that is incredibly vulnerable to human error and hidden physiological variables.
The sources make it clear that the physical size of the blood pressure cuff is the single most common point of failure. How does wrapping a piece of Velcro around an arm go so wrong?
It comes down to basic physics and pressure dynamics. The inflatable bladder inside the cuff must be precisely sized to the circumference of the patient's arm.
There are actual guidelines for the size, right?
Yes, the guidelines dictate that the width of the bladder needs to cover roughly 40% of the upper arm circumference, and the length must encircle at least 80% of it.
What happens if it's too small?
If a medical assistant uses a cuff that is too small, meaning it's too narrow and short for a larger arm, the cuff has to be overinflated to generate enough pressure to compress the brachial artery through the excess tissue.
Which means the gauge is registering all that extra wasted pressure.
Exactly, resulting in a falsely elevated reading. A patient with perfectly healthy blood pressure could be diagnosed with severe hypertension simply because the clinic used a standard cuff on a larger than average arm.
And the opposite.
Conversely, using a massive bariatric cuff on a very thin arm will disperse the pressure too broadly, failing to adequately compress the artery and yielding a falsely low reading, potentially masking a hypertensive crisis.
The Bates text then dives into a phenomenon called the auscultatory gap,
Right.
which is frankly terrifying because it reveals how an older patient can be misdiagnosed even if the cuff size is perfect.
To understand the gap, we have to visualize how the doctor actually listens to the pressure.
Right, let's break down the sounds.
When the cuff is inflated, it completely cuts off the blood flow in the brachial artery. As the clinician slowly releases the air, the pressure drops until it is just barely below the pressure of the heart pumping.
And what do they hear?
At that exact millisecond, a spurt of blood forcefully pushes past the cuff, creating turbulent flow. Through the stethoscope, this turbulent flow sounds like a distinct tapping noise. These are called carrot cough sounds.
The very first tap heard is the systolic pressure, the maximum force of the heart contracting.
As the cuff continues to deflate, the artery opens wider, the flow becomes smooth, and the tapping sounds vanish. The exact moment of silence marks the diastolic pressure, the resting pressure of the heart.
So normally it's tap starts at 120, tap stops at 80, blood pressure is 120 over 80. But the auscultatory gap ruins that clean progression.
In older patients, particularly those with severe atherosclerosis where the arteries are heavily calcified and stiffened, those tapping sounds can inexplicably disappear right in the middle of the deflation cycle, only to reappear further down.
So imagine a doctor pumping the cuff up to 160, thinking that is high enough. They start letting the air out. They hear absolutely nothing at 160, nothing at 155. Then at 150, the tapping starts.
They mentally note the systolic is 150.
The tapping continues down to 90, then stops. They write down a blood pressure of 150 over 90.
But what they didn't know is that the patient's actual systolic pressure was 210.
Whoa!
The doctor happened to inflate the cuff right into the middle of a massive silent gap that existed between 210 and 150. They completely missed the true top number because they didn't pump the cuff high enough to hear the initial sounds before the gap started.
They just sent a patient home with stroke-level hypertension, entirely unmedicated because of an acoustic illusion.
It's terrifying. But the texts outline a manual failsafe to prevent this.
What's the fail-safe?
Before the stethoscope even touches the patient, the clinician is supposed to palpate, physically feel the radial pulse at the wrist. They inflate the cuff rapidly while feeling the pulse.
Feeling for when it stops.
Exactly. The exact number on the dial when the pulse completely vanishes under their fingers is an estimate of the true systolic pressure. They then add 30 millimeters of mercury to that number, and that becomes the absolute target for inflation. It guarantees they bypass any silent gaps.
Beyond the mechanical errors, there is the intense psychology of blood pressure. The texts dedicate significant space to the different phenotypes of hypertension. We've all heard of white coat hypertension.
White coat hypertension occurs when the sheer anxiety of being in a medical environment causes a massive spike in sympathetic nervous system activity,
Driving the blood pressure up in the clinic while the patient's home readings remain perfectly normal.
It is incredibly common, affecting up to 20% of patients who present with elevated office readings.
But the clinical data highlights something far more insidious: masked hypertension.
Masked hypertension is the absolute inverse, and it is a silent cardiovascular killer. In these cases, the patient's blood pressure measured in the calm, controlled environment of the doctor's office is completely normal, often textbook 120 over 80.
But outside the clinic.
However, when that patient goes back to their highly stressful job, their chaotic home life, or simply goes about their daily activities, their ambulatory blood pressure spikes into dangerous hypertensive territory.
The statistics on this are staggering. The sources estimate that masked hypertension affects 10% to 30% of the general population. Think about that volume of people.
It is a massive epidemiological blind spot. Because their clinical numbers look pristine, these patients are never flagged for treatment,
They walk around for decades with undiagnosed, untreated high blood pressure.
silently causing microscopic damage to the inner lining of their arteries, accelerating kidney damage, and exponentially increasing their risk for a catastrophic myocardial infarction or a stroke.
It fundamentally challenges the utility of the isolated office measurement, which is why modern guidelines heavily advocate for 24-hour ambulatory blood pressure monitors that patients wear home.
Moving from the pressure in the vessels to the sensation in the nerves, we arrive at the fifth vital sign: pain.
Pain is the ultimate clinical paradox because it is entirely subjective and completely invisible. You cannot wrap a cuff around a patient's arm to measure their agony.
Because it lacks an objective biomarker, clinicians attempt to categorize pain by its underlying neural mechanism to guide treatment. The texts break this down into nociceptive pain and neuropathic pain.
Nociceptive pain is the kind of pain we are all most familiar with. It is linked to actual observable tissue damage.
With nociceptive pain, the body's entire sensory nervous system is functioning perfectly normally. It is simply doing its job by reporting that damage is occurring.
This is the pain of a twisted ankle, a surgical incision, or the severe joint degradation of osteoarthritis.
When a clinician asks a patient to describe this type of pain, the vocabulary is remarkably consistent. Patients describe nociceptive pain as a dull ache, a heavy pressing sensation, a rhythmic throbbing, or a deep colicky cramping.
Neuropathic pain is a completely different beast.
Neuropathic pain is pathological. It is the direct consequence of a lesion or a disease affecting the somatosensory system itself.
Hardware is broken.
The nerves have been damaged by a stroke, severed by a spinal cord injury, crushed by a herniated disc, or degraded by chronic high blood sugar in diabetic neuropathy. Because the nerve pathways are fundamentally altered, the pain signals they send to the brain are chaotic and bizarre.
The vocabulary patients use to describe neuropathic pain sounds violent. They describe it as an electric shock shooting down their leg, a searing, burning sensation, or the feeling of thousands of sharp pins and needles constantly pricking the skin.
Understanding that distinction is vital because standard anti-inflammatory medications that work beautifully for a nociceptive sprained ankle will do absolutely nothing to calm the damaged, misfiring nerves, generating neuropathic pain.
To attempt to quantify this invisible experience, clinics rely on standardized communication tools like the 0 to 10 numeric rating scale or the visual analog scale.
The sources also heavily feature the Wong-Baker Faces scale.
Oh, the one with the cartoon faces.
Yes, which uses a row of 6 simple cartoon faces, ranging from a broad, happy smile at 0 to a heavily crying, grimacing face at 10. It is an incredibly effective tool for pediatric patients, individuals dealing with severe language barriers, or patients experiencing advanced cognitive decline.
Standardized tools attempt to level the playing field, but this brings us to a heavily documented and critically important phenomenon detailed in the medical literature regarding pain assessment.
When subjective interpretation meets clinical decision-making, it opens the door to severe disparities driven by implicit bias.
The research data highlighted in the text is deeply sobering. There is a clearly documented, statistically significant disparity indicating a lower rate of administration for analgesic medications, painkillers, in emergency room settings for African American and Hispanic patients when compared to white patients presenting with the exact same injuries.
The data extends beyond the emergency room. It is documented in the management of chronic low back pain, post-operative surgical pain, and even the palliative management of cancer-related pain.
The texts identify several compounding factors: cross-cultural language barriers, differing cultural expressions of stoicism versus vocalization of pain, but primarily the profound impact of unconscious clinician stereotyping.
When a diagnosis relies entirely on a patient's self-reported subjective experience, any unconscious bias that causes a clinician to doubt the veracity or severity of that report results in a patient suffering needlessly.
It is a critical flaw in relying purely on subjective observation without rigorous standardized protocols.
Yeah.
If you are ever sitting on an exam table and you are asked to rate your pain, you must become your own strongest advocate.
Use definitive, highly descriptive language. Don't just say, "it hurts." Tell the clinician if it is dull throb or an electric shock. Point directly to the faces on the scale.
You are the only person who can feel the sensory input, so you have to act as the direct translator for the clinician.
That concept of translating the internal experience perfectly bridges us to the most complex terrain of the physical exam, decoding the mind, Part 3.
The Bates text provides a dense anatomical roadmap of the mental status exam, fundamentally mapping human emotion and behavior to specific geographical coordinates within the brain.
We tend to think of mood as this ethereal, philosophical concept, but the texts break it down into a highly regulated chemical transit system.
They outline the brain's primary chemical messengers, the neurotransmitters, and detail exactly where they are manufactured. Let's walk through this biological machinery, starting with serotonin.
Serotonin is primarily synthesized deep in the brainstem, specifically in a cluster of neurons known as the raphe nuclei. From this deep, ancient part of the brain, serotonergic pathways project massively outward, innervating almost the entire central nervous system.
It's the master regulator.
It governs baseline mood, maintains our state of arousal, and modulates complex cognition. When the serotonin supply from the raphe nuclei diminishes, the clinical result is the heavy, pervasive darkness of depressive symptoms.
Next is norepinephrine.
Norepinephrine originates from another tiny, distinct region in the brainstem called the locus coeruleus. Its axons spread like a vast, branching canopy across the cortex.
And what does it do?
Norepinephrine is the chemical of hyperfocus and threat detection. It regulates attention, vigilance, and arousal. The text notes a fascinating chemical interplay. When a patient has depleted levels of serotonin combined with an excessive overactive surge of norepinephrine, the resulting clinical presentation is severe, debilitating anxiety and panic.
Then we have the reward chemical dopamine.
Dopamine is produced in the substantia nigra and the ventral tegmental area. While it is famous for regulating pleasure, reward-seeking behavior, and motivation, it is also absolutely critical for smooth, coordinated motor control.
Which is why the death of dopamine-producing cells results in the tremors of Parkinson's disease.
Exactly. In the realm of psychiatry, an absolute overabundance of dopamine-flooding specific cortical pathways is heavily implicated in the grandiosity of mania and the terrifying auditory hallucinations of psychosis.
Finally, the texts detail acetylcholine.
Acetylcholine is manufactured higher up in the basal forebrain, specifically the basal nucleus of Meinert. It is the neurotransmitter of memory consolidation, learning, and sleep regulation.
A profound depletion in acetylcholine concentrations is a hallmark neurochemical signature of Alzheimer's disease and other severe dementias.
When a doctor is performing a mental health screening, they aren't reading your aura. They are actively hunting for the behavioral exhaust caused by these very specific chemical imbalances.
And the need for this screening is massive. The sources point out that approximately 20% of all primary care outpatients have an active mental health disorder. But the truly shocking statistic is that up to 75% of those illnesses go completely undetected and untreated by the primary care physician.
A 75% failure rate in detection represents a catastrophic gap in healthcare delivery. The primary reason for this massive miss rate is a phenomenon known as somatic masking.
Somatic meaning relating to the physical body.
Precisely. The texts highlight that roughly 2/3 of all patients suffering from clinical depression do not walk into a clinic and articulate, "I feel an overwhelming sense of sadness and despair."
Instead, the chemical imbalance of depression manifests physically.
They present to the doctor with relentless tension-type headaches, unexplained chronic gastrointestinal distress, debilitating lower back pain, or a crushing sense of physical exhaustion.
The mind hides the illness inside the body. So how does a doctor penetrate that physical disguise to screen for the underlying mental crisis?
They utilize highly validated rapid screening tools like the Patient Health Questionnaire 9 or PHQ-9. They systematically ask about the two absolute hallmark criteria for major depressive disorder.
First, they ask about depressed mood. Over the past 2 weeks, have you frequently felt down, depressed, or entirely hopeless?
Second, they screen for anhedonia, the complete loss of the ability to experience pleasure. Have you felt little to no interest or pleasure in doing things you usually enjoy?
If the patient answers yes to those physical and emotional prompts, the clinician immediately probes deeper into the physiological symptoms.
Severe insomnia or hypersomnia, significant appetite changes, poor concentration, and crucially, they must explicitly ask about any active thoughts of death or self-harm.
When screening for anxiety disorders, the time frame shifts. The clinician is looking for a history of excessive, uncontrollable worry that has persisted for at least 4 weeks, or the sudden, terrifying onset of unexpected panic attacks.
They have to carefully delineate the nature of the anxiety. Is it a generalized, free-floating worry, a phobic avoidance of specific triggers, or an obsessive, intrusive thought pattern?
The mental status exam also deeply analyzes the mechanics of human communication, speech, thought, and perception. The texts dive into aphasia,
Which is a profound disorder of language comprehension or production, almost always resulting from a stroke or severe traumatic brain injury.
They highlight the dramatic difference between two common types, Broca's aphasia and Wernicke's aphasia.
The clinical lecture provided an incredibly useful mnemonic device for these. Broca's is broken.
Broca's area is located in the frontal lobe, heavily tied to the motor functions required to physically produce speech.
In Broca's aphasia, the patient's comprehension remains entirely intact. They perfectly understand everything you are saying to them. However, their ability to articulate a response is shattered.
Their speech is agonizingly slow, labored, non-fluent, and literally broken into isolated, strained words. The patient is fully aware of their deficit, leading to immense visible frustration.
And then Wernicke's is wordy.
Wernicke's area is located in the temporal lobe, and it governs the actual comprehension of language.
Wernicke's aphasia is a receptive aphasia. These patients speak with incredible fluency, normal rhythm, and rapid speed. However, because their comprehension center is destroyed, the words they string together lack any coherent meaning.
They will confidently speak in long, grammatically smooth sentences populated entirely by malformed words or entirely invented nonsense words.
Tragically, they generally have no awareness that what they are saying is completely unintelligible to the person listening.
That concept of invented language perfectly bridges into how doctors assess a patient's underlying thought processes. The clinical lecturer used a brilliant, highly recognizable pop culture example to demonstrate what severe abnormalities in thought processes actually sound like.
She pulled up the infamous 2011 television interview with actor Charlie Sheen.
It remains a masterclass in observable psychiatric symptomatology. During that period, Sheen repeatedly used phrases like claiming he possessed tiger blood and Adonis DNA.
Clinically, those bizarre, invented phrases are classified as neologisms.
Why does the brain invent new words?
In states of extreme mania, psychosis, or substance-induced delirium, the neural pathways are firing at a hyperactive, chaotic rate. The brain is attempting to bridge massive cognitive gaps to express highly idiosyncratic, grandiose concepts that don't map to standard vocabulary.
So it simply invents a new term and treats it as a universally understood fact.
The Sheen interview also provided textbook examples of two other major thought process disorders: circumstantiality and derailment.
Let's break down the difference between how those two sound in a conversation.
Circumstantiality is speech characterized by agonizing indirection and unnecessary hyperspecific detail. If you ask a patient with circumstantiality how they got to the clinic, they won't say, "I drove."
What do they say?
They will tell you about the exact temperature of their car engine, the make and model of the car in front of them at a specific stoplight, and the lyrics of the song playing on the radio. The key diagnostic feature, however, is that they do eventually reach the point of the story. They just take a massive circular detour to get there.
Derailment, on the other hand, never reaches the destination.
Derailment, also known as the loosening of associations, is when the train of thought completely flies off the tracks. The speech shifts abruptly, rapidly, and repeatedly from one completely unrelated topic to the next without any apparent logical connection whatsoever.
A patient might seamlessly transition from talking about their breakfast to the geopolitics of the Cold War to the color of the doctor's shoes in a single unbroken sentence.
The Sheen interview was a barrage of derailment, showcasing a rapid progression of fractured ideas untethered from shared reality.
The assessment of reality also involves distinguishing between different sensory errors. The texts draw a very firm line between an illusion and a hallucination.
This is a vital diagnostic fork in the road. An illusion is a neurological misinterpretation of a genuine, existing external stimulus.
If a patient is lying in a dark hospital room, hears the actual rustling of leaves outside the window, but their brain misinterprets that real acoustic data as the sound of someone whispering their name, that is an illusion.
The physical stimulus exists, the processing is flawed.
A hallucination requires absolutely no external input.
A hallucination is the brain generating a sensory experience out of thin air. The patient perceives a vivid auditory voice commanding them to act. a terrifying visual entity standing in the corner of an empty room, or even a tactile sensation of insects crawling beneath their skin in the complete absence of any actual stimulus.
Hallucinations are severe red flags for acute delirium, advanced schizophrenia, extreme post-traumatic stress disorder, or severe alcohol or substance withdrawal.
To test the hardware of the brain in real time, to see if the cognitive processing speed is intact, doctors deploy specific mental stress tests. They don't just ask a patient, "How is your memory holding up?"
They put them through a neurological obstacle course.
To explicitly test sustained attention and immediate recall, they utilize the digit span test. The clinician will clearly recite a random series of numbers, starting with 2 digits, and ask the patient to repeat them back.
They sequentially increase the length, 3 digits, 4 digits, 5 digits.
A neurologically healthy individual should easily be able to repeat a string of 5 digits forward. The clinician then increases the cognitive load by asking the patient to repeat a new string of digits entirely backward. Normal function dictates they should manage at least a 4-digit sequence in reverse.
Then there is the universally dreaded serial sevens test. The doctor asks the patient to start at the number 100, subtract 7, state the answer aloud, and continually subtract 7 from the new number, 93, 86, 79, 72.
The clinician is silently monitoring the mathematical accuracy, but more importantly, the speed and the visible cognitive effort required. If a patient cannot perform the math, the backup test is asking them to spell the word world backward, DLROW.
These tests aren't designed to measure intelligence or math skills. They are designed to isolate and stress the brain's concentration networks.
Inability to maintain the sequence is often the very first subtle indicator of an impending state of delirium or the overwhelming cognitive interference of severe anxiety.
They also test the brain's ability to engage in abstract thinking by using traditional proverbs.
This tests the higher-order executive functions of the frontal lobe. The clinician will ask the patient to explain the meaning of a common proverb, such as, "A stitch in time saves 9."
If the patient relies on literal interpretation and says, "It means you should sew a rip in your shirt before the hole gets bigger," that is classified as a concrete response.
But if the patient synthesizes the underlying metaphor and replies, "It means that prompt attention to a small problem prevents it from turning into a massive disaster," that is an abstract response.
A shift from abstract reasoning to highly concrete, literal thinking is a strong indicator of organic cognitive impairment, progressing dementia, or acute brain injury, though a clinician must always carefully calibrate this test against the patient's specific educational, linguistic, and cultural background.
The most visually striking cognitive test detailed in the sources is the clock drawing test. It is used to evaluate constructional ability.
The clinician literally hands the patient a blank piece of paper and a pen and gives a very simple instruction. Draw a clock face, put in all the numbers, and set the hands to a specific time, like 10 past 11.
It masquerades as a simple kindergarten drawing task, but neurologically it requires an immense, highly coordinated symphony of brain functions.
It requires profound visuospatial skills mediated by the right parietal lobe to understand the geometry of a circle.
It requires executive function and planning from the frontal lobe to evenly space out the numbers 1 through 12. It requires motor execution and semantic memory to remember what a clock actually looks like.
The resulting drawings provide an instant, tangible snapshot of neurological devastation. A patient with severe parietal lobe damage might draw a perfect circle, but bunch all 12 numbers tightly onto the right side of the clock face, entirely neglecting the left side of space.
A patient with advancing Alzheimer's might draw random geometric shapes that bear absolutely no resemblance to a clock. Or they might draw the hands pointing outward, entirely disconnected from the center point.
It is a diagnostic masterpiece because the evidence of cognitive decline is physically printed on the page in front of you.
Speaking of cognitive decline, the medical texts draw an incredibly sharp life-or-death line between dementia and delirium.
The clinical distinction between those two states dictates entirely different emergency responses. Dementia is an overarching clinical syndrome characterized by a slow, insidious, and largely irreversible progressive decline in memory, language, and executive function.
The absolute defining characteristic of dementia is that the patient's baseline level of alertness and consciousness remains perfectly intact until the very terminal stages of the disease. A patient with Alzheimer's is awake, alert, and tracking you with their eyes. It is the data retrieval system that is failing.
Delirium is a completely different neurological emergency. It is an acute, sudden onset confusional state.
Delirium happens fast, often over hours or days. The The hallmark feature of delirium is profound inattention and a wildly fluctuating level of consciousness.
The patient may be highly agitated and hallucinating in the morning, and completely lethargic and unarousable by the afternoon.
Delirium is the brain's distress signal that the body is under a severe systemic attack. It is highly linked to hidden, overwhelming infections, like a urinary tract infection in an elderly patient, severe adverse medication reactions, or dangerous metabolic imbalances.
Dementia is a chronic condition to be managed. Delirium is an active fire alarm requiring immediate hospitalization to find the hidden physical cause before the brain sustains permanent damage.
We've talked about how the brain leaks clues about our mental state through our speech and cognition. But there is another organ that is constantly, relentlessly betraying our internal physiological secrets to the observing clinician.
It is the largest organ we possess, the skin. This brings us to part 4, the body's canvas. The skin displays a staggering array of data, from localized malignancies to the cutaneous manifestations of systemic organ failure. Let's dive into reading the skin for melanoma using the universally taught ABCDE rule.
Melanoma is an incredibly aggressive, highly deadly form of skin cancer that arises from the pigment-producing cells known as melanocytes. Early detection through visual observation is the absolute key to survival.
The ABCDE mnemonic provides a structured geometric analysis of any pigmented lesion. A stands for asymmetry. If you draw an imaginary line directly through the center of a mole, the two halves should be mirror images.
If one half is wildly misshapen compared to the other, the cellular growth is unregulated, which is a massive warning sign.
B is for border. You want the edges of a mole to be crisp, smooth, and well-defined. If the border is jagged, ragged, deeply notched, or blurred into the surrounding skin, it indicates the rogue cells are actively invading the adjacent tissue.
C evaluates color. A benign mole is typically a uniform shade of tan or brown. A melanocytic lesion becomes highly suspicious when it displays a chaotic variety of colors within the same bump, a chaotic mixing of dark blacks, deep browns, sudden patches of blue, or inflammatory redness.
D stands for diameter. The general rule of thumb is that any lesion larger than 6 millimeters, which is conveniently the exact diameter of a standard pencil eraser, requires immediate clinical evaluation and likely a biopsy.
And finally, E is for evolution, and this is arguably the most critical metric. Regardless of its size or shape, if a lesion is actively changing, if it is rapidly growing, suddenly changing color, elevating, or newly exhibiting symptoms like severe itching, crusting, or unprovoked bleeding, it must be treated as a malignancy until proven otherwise by a pathologist.
The clinical lecture provided a fascinating masterclass in how doctors communicate about the skin. They utilize a very specific lexicon of bumps. They don't just call something a rash, they use a highly specific vocabulary based on the precise geometry and fluid dynamics of the lesion.
This shared vocabulary allows a dermatologist to close their eyes, listen to a description over the phone, and perfectly visualize the pathology.
The primary distinction relies on elevation. If a skin lesion is completely flat, meaning you can run your finger over it with your eyes closed and feel absolutely no change in texture or height, it's classified as a macule if it is small, like a standard freckle.
If that flat area of discoloration is large, it is called a patch, such as a large port wine stain birthmark.
If the lesion is elevated above the surface of the skin, the vocabulary changes. A small, solid, elevated bump is a papule.
If that raised area expands to become a broad, flat-topped plateau of thickened skin, it is termed a plaque, which is the hallmark presentation of psoriasis.
The terminology shifts again if the elevated lesion is filled with fluid. If the bump contains a collection of clear, serous fluid, it is a vesicle if it is tiny, like the classic presentation of a cold sore or a small friction blister.
If that clear, fluid-filled pocket is massive, it is classified as a bulla. The clinical lecture spent significant time highlighting a severe condition known as bullous pemphigoid.
That sounds incredibly painful. What is the mechanism behind a bulla that large?
Bullous pemphigoid is a brutal autoimmune disease, typically seen in the elderly population. The patient's own immune system generates autoantibodies that mistakenly attack the structural basement membrane zone, the vital layer of molecular glue that binds the outer epidermis to the deeper dermis.
As that glue is destroyed, the layers shear apart, and the resulting massive void violently fills with serous of fluid, creating huge, tense, severely itchy, clear blisters all over the patient's torso and limbs.
And if the bump is not filled with clear fluid, but rather filled with opaque yellowish-white pus, it is categorized as a pustule. The classic example is severe inflammatory acne.
The lecturer made a very specific, slightly humorous point to the medical students. Always use the professional medical term purulent fluid in your official clinical notes, rather than describing a wound as pus-filled.
It is a wise piece of professional advice to maintain the academic rigor of the medical record.
We transition from the specific terminology of bumps to the chaotic world of pediatric rashes. The lecturer delivered a fantastic, highly pragmatic quote regarding pediatric dermatology. It is the kid's job to get a rash. It is the parent's job to panic and worry. And it is the clinician's job to calmly reassure.
The truth behind that quote is that the vast majority of terrifying-looking childhood rashes are ultimately benign viral exanthems, the skin's temporary immune reaction to a passing virus or simple contact dermatitis from rolling around in the grass.
However, clinicians are trained to quickly scan for very specific visual patterns that dictate treatment. For instance, molluscum contagiosum is a highly contagious viral skin infection. It presents as a cluster of distinct, firm, flesh-colored, dome-shaped papules.
The critical identifying feature is that they are umbilicated, meaning each little dome has a distinct tiny crater or dimple right in the center, making them look like miniature donuts.
Impetigo is another highly common pediatric infection, usually caused by staph or strep bacteria. It typically erupts around the child's nose and mouth. The initial blisters quickly rupture, leaving behind a very characteristic thick exudate that the textbooks universally describe as honey-colored crusts.
And then there is tinea corporis, universally known by the highly misleading public name of ringworm. It has absolutely nothing to do with a worm. It is a superficial fungal infection.
The fungus consumes the keratin in the skin, expanding outward in a perfect circle. This creates an annular or ring-shaped lesion.
The advancing border is highly red, elevated, and scaly, while the trailing center of the circle exhibits central clearing, returning to the appearance of normal skin as the fungus marches outward.
Moving from the superficial layers of the skin into the much darker reality of deep tissue damage, the texts cover the management of wounds and ulcers, which is a massive, relentless battle in acute care hospitals and long-term nursing facilities. We're looking at a tale of three distinct types of wounds, driven by completely different physical mechanisms. First, we have pressure injuries, commonly referred to as bed sores.
Pressure injuries are entirely mechanical. They are caused by prolonged, unrelieved pressure, combined with friction and shear forces, usually occurring over bony prominences like the heel, the sacrum, or the back of the head in immobile, bedbound patients.
The constant pressure physically crushes the microvasculature, cutting off the blood supply and causing the tissue to slowly suffocate and die. They are rigorously staged by their depth of tissue destruction.
Stage 1 is the earliest warning sign. The skin is completely intact, but there is a localized area of intense redness. The key is that it is non-blanching. If you press your finger firmly into the red spot and let go, the skin does not temporarily turn white. The tiny blood vessels are already engorged and damaged.
Stage 2 involves the actual partial thickness loss of the dermis. The skin breaks open. It typically presents as a shallow, painful, open ulcer with a red or pink wound bed, or it might look like a freshly ruptured blister.
Stage 3 is where the destruction becomes massive. It is a full-thickness tissue loss. The ulcer has cratered so deeply that the subcutaneous fat layer is fully visible, though you cannot yet see any underlying bone or muscle tissue.
Stage 4 is the catastrophic extreme. It is full-thickness tissue loss that completely exposes the underlying skeletal framework. You can clearly see the white of the bone, the gleaming white tendons, or the red striations of the muscle.
Patients with stage 4 injuries are at a massive, life-threatening risk for osteomyelitis, which is a deep, intractable infection of the bone marrow itself. The texts also note an unstageable category.
This occurs when the entire base of the deep ulcer is completely obscured by a thick layer of yellow slough or a hard, leathery black scab called eschar. Because the clinician cannot physically see the bottom of the wound bed, they cannot legally assign a stage until that necrotic armor is surgically removed.
Then you have lower leg ulcers, and the medical texts emphasize how incredibly crucial it is to differentiate between arterial ulcers and venous ulcers. They might look somewhat similar to the untrained eye, but the underlying vascular physics are entirely opposed.
You have to understand the plumbing. Arteries carry highly pressurized, oxygenated blood down from the heart to the toes. Veins rely on valves and muscle contractions to fight gravity and carry the deoxygenated blood back up to the heart.
Arterial ulcers occur when the arterial pipes are severely clogged with atherosclerotic plaque peripheral arterial disease. The blood simply cannot flow down to the tissue. Because the tissue is starving for oxygen, arterial ulcers typically form at the absolute furthest points from the heart, the tips of the toes, the top of the foot, or the lateral side at the ankle.
They look like someone took a perfect circular hole punch to the skin. The edges are incredibly smooth, and the surrounding skin is characteristically pale, shiny, cool to the touch, and completely hairless, because hair follicles require massive blood flow to survive.
And the defining characteristic of an arterial ulcer is the pain mechanism regarding gravity. These ulcers hurt exponentially more when the patient elevates their leg up on a pillow. By elevating the leg, they're forcing the already compromised arterial pressure to fight uphill against gravity, further starving the tissue of oxygen.
They often have to dangle their foot over the side of the bed just to get enough gravity-assisted blood flow to stop the agonizing pain.
Venous ulcers are the exact mechanical opposite. In chronic venous insufficiency, the arterial blood successfully travels down to the leg, but the one-way valves inside the veins have failed. The veins cannot pump the blood back up to the heart. Consequently, massive amounts of blood and fluid pool in the lower leg. The massive hydrostatic pressure causes the veins to leak fluid and red blood cells into the surrounding tissue.
This pooling effect dictates the location. Venous ulcers almost always occur in the gaiter region, the fleshy area between the knee and the inner ankle. Unlike the neat, hole-punch look of an arterial ulcer, venous ulcers are sprawling, shallow, and highly irregular in shape. The entire lower leg is usually massively swollen with edema, and the skin takes on a thick, brawny, dark, brownish discoloration.
That brown staining is called hemosiderin deposition. It is literally the iron pigment left behind from the thousands of red blood cells that leaked into the tissue and died. And conversely to arterial issues, patients with venous ulcers experience massive relief when they elevate their legs because elevation finally allows gravity to help drain the pooled, stagnant blood back toward the torso.
Let's finish up the observation of the body canvas with the extreme outposts, the hair and the nails. The text revealed that a quick glance at a patient's fingernails provides an immediate window into the health of their internal organs.
The nail matrix is highly sensitive to systemic metabolic changes. Clinicians look for koilonychia, commonly known as spoon nails. The nail plate physically inverts, becoming concave enough that it looks like a small scoop. This bizarre structural deformity is a classic, highly specific indicator of severe iron deficiency anemia or hemochromatosis, an iron overload disorder.
They also examined the color distribution, looking for Terry's nails. In this condition, the vast majority of the nail plate turns stark white, obliterating the normal pink crescent, leaving only a sharp, narrow band of dark pink or brown at the very distal tip of the nail. Terry's nails are deeply associated with profound liver disease, advanced cirrhosis, or congestive heart failure.
When evaluating hair, they aren't looking at the styling. They are looking for highly specific geographic patterns of loss. We mentioned alopecia areata earlier. It is an autoimmune attack on the hair follicles that results in sudden, perfectly smooth, sharply defined circular patches of complete hair loss on the scalp.
This looks entirely different from tinea pies, which is the fungal ringworm infection occurring on the scalp. The fungus weakens the hair shafts, causing them to snap off right at the surface, resulting in a patch of scalp covered in scaly skin and tiny broken black dots of hair.
This intensive focus on the physical examination of the hair brings us to the most visceral, memorable anecdote from the clinical lecture transcripts.
Oh man, this story is permanently burned into my brain. The lecturer was recounting a situation from a colleague who was working in a highly impacted community clinic in Boston. A patient walked into the exam room complaining of an itchy scalp. From a distance, the clinician thought the patient's hair looked strangely textured.
But as the clinician adhered to the general survey protocol and stepped in close to physically part the hair under the exam light, they realized the true extent of the pathology.
The infestation of head lice was so unimaginably severe, so incredibly dense, that the sheer volume of the insects moving in unison made the patient's hair appear to be literally rolling in physical waves. The hair looked alive.
It is a deeply unsettling image, but it serves as the ultimate visceral reminder of why a thorough, up-close, systematic physical observation is absolutely paramount in medicine. You cannot diagnose a patient from the doorway, regardless of how uncomfortable the odor might be, regardless of how visually shocking the wound might be, or how squirm-inducing the infestation is. The clinician is obligated to step forward, part the hair, lift the skin folds, and press on the nail beds.
The diagnostic data is physically written on the body. You just have to have the discipline to read it.
So we have gathered all of this immense data. The doctor has observed the mechanics of your posture, outsmarted the physical illusions of the blood pressure cuff, categorized the neurological pathways of your pain, mapped the neurotransmitter imbalances in your speech, tracked your memory with reverse spelling, staged your skin ulcers, and analyzed the iron content in your fingernails.
How does all of this Sherlock Holmes-level deduction actually get translated into the massive bureaucratic machinery of the medical system?
This is where we transition to the final section of our sources. Part 5, Translating Observation to Action, via the Evaluation and Management Coding Matrix. This is the intricate, often frustrating business side of modern healthcare.
Right. Doctors do not bill by the hour like lawyers, and they do not charge a flat rate per physical exam. To legally bill an insurance company or Medicare for their time, their diagnostic expertise, and the legal liability they assume, clinicians must translate every single clinical finding into specific, rigid levels of complexity using the EM coding tools.
The matrix categorizes every single patient visit into one of 4 distinct tiers: straightforward, low complexity, moderate complexity, or high complexity.
It is crucial to understand that this coding matrix is not just administrative busywork delegated to a billing department. It serves as the fundamental legal and medical justification for the entire level of care provided. It proves to the medical board and the insurance auditors that the clinician's thought process was sound.
The overall complexity of a visit is calculated using a strict algorithm based on 3 specific pillars of medical decision-making.
The formula of complexity. Let's break these pillars down. Pillar number 1 is the sheer number and complexity of the medical problems addressed during that specific visit.
If a healthy patient comes in with one self-limited, minor problem, say, a simple contact dermatitis rash from brushing against poison ivy, that entirely limits the problem pillar to the straightforward or low complexity category. The diagnosis is clear, and the physiological threat is minimal.
However, if a patient presents with one or more chronic illnesses that are currently experiencing a severe exacerbation, or an acute undiagnosed illness that poses an immediate threat to life or bodily function, that presentation immediately maxes out the problem pillar, pushing it squarely into the high complexity category.
Pillar number 2 evaluates the sheer amount and complexity of the data that the clinician must review and analyze to make a safe decision.
This is the data aggregation pillar. It tracks the cognitive work of gathering the puzzle pieces. Did the doctor have to manually review massive files of prior clinical notes from external out-of-network specialists? Did they have to order and independently interpret a complex array of new laboratory tests or radiological imaging?
Did the clinician have to spend significant time obtaining a detailed medical history from an independent historian, like a spouse, a paramedic, or an adult child, because the patient's own mental status was heavily compromised by delirium or dementia? The more external data streams the clinician has to synthesize, the higher the data complexity metric climbs.
And finally, pillar number 3 evaluates the raw risk of complications and morbidity associated with the patient management decisions made during the visit.
This pillar looks directly at the danger inherent in the proposed treatment plan. Are you simply being advised to rest and apply ice to a sprained joint? That is low risk. Are you being prescribed standard daily medication for a stable condition? That escalates the risk to moderate.
Or is the clinician putting you on a highly volatile, narrow therapeutic index drug therapy that requires intensive ongoing laboratory monitoring to prevent severe organ toxicity? Are they making a real-time, high-stakes decision regarding the immediate need for emergency major surgery? Or having a profound discussion regarding the implementation of a do not resuscitate order? Those interventions max out the risk pillar at high.
So if we synthesize all 3 pillars and look at a few examples of how a visit is graded. A straightforward visit is mathematically simple. It is a healthy patient presenting with a minor ankle sprain. It represents one minor problem, requires minimal data review, maybe a single clean x-ray, and involves a very low-risk treatment plan of a compression wrap and over-the-counter ibuprofen.
A moderate visit is the absolute bread and butter of primary care medicine. This would be a patient presenting for a routine checkup, but they are actively managing 2 stable chronic illnesses, such as type 2 diabetes and primary hypertension. The doctor is engaging in moderate-risk prescription drug management, adjusting the dosages of insulin and blood pressure medications based on the review of recent lab panels.
And a high-complexity visit is a clinical fire drill. It is a patient arriving with a severe acute exacerbation of chronic obstructive pulmonary disease, struggling to breathe, tripoding on the exam table. The clinician is rapidly synthesizing oxygen saturation data, arterial blood gas results, ordering immediate aggressive steroid interventions, and making a high-risk decision regarding whether the patient needs to be admitted to the intensive care unit or intubated.
Exactly. The matrix algorithm requires the clinician's documentation to explicitly meet or exceed the criteria in at least two out of those three pillars to legally and financially justify the overall complexity level of the visit bill to the insurance provider.
The ultimate realization here is profoundly eye-opening. When a doctor is sitting across from you, asking seemingly random questions about your sleep, checking the wear pattern on the soles of your shoes, asking you to interpret what a stitch in time saves 9 means, or asking you to draw a clock face on a scrap of paper, they aren't just making polite conversation to pass the time.
They are engaged in an intense, simultaneous data-gathering operation. They are gathering the physiological clues to crack the diagnostic case, while concurrently fulfilling the rigorous algorithmic requirements of the coding matrix to legally justify the medical care they're providing.
It highlights an incredibly demanding, often unappreciated cognitive burden placed on the modern physician. For the entire duration of the visit, they are actively running a massive, high-speed parallel processing track in their mind. One track is dedicated to the ancient, deeply empathetic art of patient care, intuition, and medical diagnosis. The second, parallel track, is constantly running the rigid algorithmic logic of the EM coding tools, calculating risk matrices and data requirements in real time. It is a staggering mental balancing act.
Which brings us to our summary and reflection on the sources we have unpacked today. We have been on an incredibly dense, fascinating journey. We started with the silent power of the first glance in the general survey, realizing that our clothing choices, our grooming, and the angle of our posture broadcast a loud medical narrative long before we ever speak.
We deconstructed the mechanical physics and the hidden psychological traps of taking vital signs and assessing the invisible world of pain. We dove deep into the neuroanatomy, exploring the chemical transmitters and the cognitive stress tests that allow doctors to decode the inner workings of the mind.
We traveled across the vast, revealing canvas of the skin, hair, and nails, learning to read the lexicon of bumps and the geometry of ulcers. And finally, we saw how every single one of those granular human observations gets rigidly codified into the complex business matrix of the modern healthcare system.
The overarching takeaway from all these texts is that the human body is a spectacularly complex, continuously broadcasting transmitter of physiological and psychological health data. The refined art of clinical observation is simply the lifelong process of a physician learning how to tune their internal receiver to the exact right diagnostic frequency.
The next time you sit in a brightly lit doctor's office or wait in an exam room, you're going to possess a completely different understanding of exactly what is happening in the silence. When the doctor checks the capillary refill in your nail beds, notes the specific heavy clothing you wore on a warm day, or listens closely to the rhythmic cadence and word choice of your speech, you will know that they are actively hunting for the hidden clues. You are a walking, breathing, complex medical story, constantly revealing your secrets.
But diving into the deep end of human observation raises an incredibly important question about the trajectory of medicine, and it serves as a final provocative thought to leave you with. We have spent this entire deep dive rigorously analyzing the deeply human, highly nuanced, and sometimes flawed art of clinical observation. But as we rapidly move into the technological future, we have to ask, what is the ultimate fate of the human-led general survey?
We are currently witnessing the massive, rapid deployment of AI-powered computer vision systems in clinic waiting rooms, capable of analyzing gait and posture in milliseconds. We have wearable technology seamlessly monitoring our pulse, oxygen, and blood pressure 24 hours a day.
In the very near future, will a sophisticated camera array and a diagnostic algorithm completely perform, analyze, and diagnose our entire general survey before the human doctor even touches the handle of the exam room door? From a purely diagnostic standpoint, the AI will never suffer from inattentional observation bias. It will never fail to see the severe burn victim simply because it is running the software for plastic surgery.
It will calculate the precise geometry and color variation of the ABCDEs of your moles with absolute pixel-perfect mathematical precision, completely free of the fatigue that plagues a human clinician at the end of a 14-hour shift.
But if we entirely outsource the act of looking to a flawless, unblinking algorithm, what invisible, uniquely human nuances are we destined to lose in that process? Can a machine learning model truly comprehend the profound, heavy despair radiating from a slumped, defeated posture, or will it merely calculate the physical degree of the spinal curvature?
The efficiency of the machine is undeniable, but it forces us to consider the unquantifiable healing value of a shared human gaze. We will leave you with that to chew on. Keep your eyes open, keep analyzing the world around you, and keep diving deep.